Okay, thank you very much and welcome everybody. So several things and then we'll get going. First of all, I want to thank Ann and Richard for not only conceiving of the program, but finding the speakers and getting everything set up. As a number of you have probably observed, we've made a bit of a shift in the operation of Health TechNet recently, and those who think of an idea for a program are frequently punished for that by being tasked with finding a speaker and arranging the program. So no good deed goes unpunished, or at least that's our goal as we move forward. We do have a couple of other interesting programs coming up that I want to highlight for you. Our July program, which will be on July 23rd, that's a change to the fourth Friday rather than the third, is going to be a brief regulatory review of what states have enacted on telehealth and that sort of thing. Deanne Kasim has agreed to kind of orchestrate putting that together. She's got a couple other topics she's going to be talking about. Deanne, do you want to say just a word about that?
Sure, thanks, Jim. So we will be looking at where we are on telehealth in terms of coverage and payment parity. The states did some action on that. Of course, Congress is debating several bills. And then we also wanted to incorporate some discussion from two rural provider systems about how the pandemic has really impacted them revenue-wise, as well as what are their thoughts on virtual care moving forward. What should it look like? What should payment parity look like? So more to come. I'm in the middle of finalizing some speakers, but that's what we have on tap for July.
Okay, thank you very much. For August, we're going
Deanne,
to, sorry. Go ahead, David.
Jim, I'm sorry. Deanne, it's David. We have a special guest who is your friend, I believe. Would you like to introduce her?
Sure, thanks, David. Allison Viola is here today. She's joining us from the Office of the Inspector General at HHS. Allison, thanks for joining. I'm so excited you could be with us. She has a long background in health IT policy, including working at a consulting firm, EHI. I could go on, but Allison, thanks for being here.
Thank you for allowing me to participate. I'm really looking forward to the conversation today.
Great. Glad you're here, Allison. Good to meet you. Our August program is, well, August meeting will not be a program. It's going to be two things that'll be kind of new, for not new, but reinstituted for us. We're going to get together face to face, and we're going to get together for lunch at a place either in Arlington or Tyson's Corner, to be determined, where we'll just have lunch and talk about anything other than healthcare. There are a number of really important topics on the table, including the nationals, the status of the PGA Tour events. I'm sure you all have other things as well. So more information will be coming on that. In September, we're going to be doing a joint program with George Mason University on cybersecurity. And we're going to be doing that at the George Mason Arlington campus, which is a really nice facility that we've previewed. We have invitations out to the Chief Information Security Officers of HHS and CMS. So we're hopeful that we'll have some pretty good speakers for that. We've got some other things lined up and are going to be starting the detailed development there. That will be a Thursday evening meeting. It'll be Thursday evening, September 23rd. It'll be from 6 to 8:30, and we'll start with an open bar and then light hors d'oeuvres, and then the program, similar to the way the DC chapter of HIMSS does their meetings. So we'll be trying that, and we've got high hopes for that. So with those announcements, and more of those things will be coming, let me turn it over to Richard and Ann again with thanks for putting this program together. Richard, I think you were going to introduce the topic and then turn it over to Ann to introduce the speakers. Is that accurate?
Jim, that's absolutely correct. So I'll just kick up the topic and then pass it over to Ann. First of all, I just want to say hi to Allison. Welcome as well. I was over in the Office of National Coordinator for Health IT a few years ago, actually the original one with Dr. Brailer. So it's great to meet folks over there again. So the motivation for today's talk as follows. Obviously, environment with the new administration is really front and center. But even before the administration, we had all these issues that keep coming to the top, whether it's water quality in Michigan, or other environmental factors. And so we thought it was really a great time to kind of look at what was going on in the US and in the world, but also because of the new political exigencies around that. So the topic for today is really environment and its impact on health. And then we're going to first hear some high-level perspectives of what that means, what are some key things going on in the environment. And then what we like to do at Health TechNet is also then drill down and say, what does that mean for local businesses and enterprises, whether it's startups or major hospital systems? How does this really play out at ground zero? With that, I'd like to hand it off to Anne, who will introduce our speakers.
Thank you, Richard. Our speakers today are really experienced in the topic at hand. They are actively writing, advocating, and working in the field. And I think we're extraordinarily lucky to get them. Thank you again. I'm going to introduce them in the order with which they're going to speak. So we're going to start with Brad Hurley, Senior Communications Consultant at ICF International. And Brad, while he can't be on the video today, really puts the international in our topic today because he is calling in from Montreal, Canada. And Brad has more than 30 years of experience as a science writer and technical editor on climate change and other global environmental challenges. He has written and contributed to reports, journal articles, and website content on climate change and public health, including a State of the Science paper on the risks posed by climate change to older Americans, a report also on the US EPA on mapping vulnerable populations, and a variety of heat health materials for EPA's Heat Island Effect website. Brad is a former science journalist and environmental educator, and he specializes in translating complex scientific information for non-technical audiences. Our second speaker is Dr. Mona Sarfati, and I please correct me, you all, if I mispronounce the name. Mona is a medical doctor, a master's of public health, and a fellow of the American Academy of Family Physicians. She is also the director of the program on climate and health within the Center for Climate Change Communications at George Mason University. And she's also the director and the founder of the Medical Society Consortium on Climate and Health. She received her medical degree from the State University of New York at Stony Brook, her Master's of Public Health from George Washington University, and her BA from Harvard. As the founder of the Medical Society Consortium on Climate and Health, she advances the issues of climate change and health by bringing together associations that represent more than 600,000 clinical practitioners to carry three simple messages to the population. One, that climate change is harming Americans, and these harms will increase unless we act. Secondly, the way to slow or stop these harms is to decrease the use of fossil fuels and increase energy efficiency, as well as increase the use of clean energy sources. And finally, these changes in energy choices will improve the quality of our air and water and bring immediate health benefits. Our third speaker is Chip Goyette, Director of Sustainability at Inova Health System. Chip oversees the system-wide implementation of a comprehensive set of sustainable practices at hospitals and healthcare facilities across Northern Virginia. He and his team are executing a multifaceted enterprise program so that patients and team members alike can benefit from having a healthier experience at each and every Inova facility. He's also a member of the Healthcare Climate Council, a leadership body of health systems committed to protecting their patients and employees from the health impacts of climate change and becoming anchors for resilient communities. So with that, please, Brad, thank you for being our first speaker.
Thanks, Anne. And I'm sorry that I'm not on video. It's not for any technical reason. It's just because I had emergency eye surgery a couple days ago and my face is kind of a mess. I'm not very presentable right now. So I'm going to go ahead and share my screen here. Let me just pull up my presentation. This is it. Okay, you should be able to see my screen. Yep. Okay.
Yes,
good.
we can.
Great, thanks. So, so this is really a brief 10,000-foot overview of climate change and public health. This is a big topic I'm going to try to cover in about 10 minutes. So the first slide here, so climate change has both chronic and acute aspects. So you have long-term changes in averages, like average temperature, average precipitation, and sea level, for example, and those lead to long-term changes in environmental conditions. But those long-term changes, those chronic changes, also have an effect on the severity and in some cases the frequency of acute events, extreme weather events such as storms and floods and droughts and heat waves. And both of those things can have impacts on health. So for example, you can have long-term warming that increases the length of, say, the growing season, and that can lengthen or change the timing of the pollen season for allergy sufferers, or it can make it possible for allergenic species to expand their ranges or to become more prevalent. And then you can also have an increase in acute events such as heat waves or floods that create health and safety emergencies for lots of people. So this first slide, this is from an assessment of the risks of climate change to public health that was published by the U.S. Global Change Research Program a few years ago. This diagram illustrates climate drivers and the exposure pathways, and then some of the contextual factors you see on both sides that influence climate-related health outcomes in different populations. And we could spend an hour on this slide, but there are lots of points you could draw from it. But I think I'd like to draw your attention to really just 2 points in particular. One is that if you look at the exposure pathways, which is this sort of the blue in the center, and you look at, so we have the climate drivers of increase that I just described, increased temperatures, precipitation extremes, extreme weather events, sea level rise. When you look at the exposure pathways, you see things like extreme heat, poor air quality, reduced food and water quality, changes in infectious agents, that's, like ticks and so forth, and population displacement. So these are climate change. I think one message is that climate change isn't really bringing anything that's totally new and unfamiliar. We have experience with most of these things. What's new is the frequency, the severity, and the scale. So, we generally think of climate as stable. Of course, there's year-to-year variability, and there are natural cycles like El Nino, and there are longer-term cycles that are driven by changes in the Earth's orbit around the sun that causes ice ages and so forth. But in the past, at least in our life history, we could make reasonably reliable plans and risk assessments, such as flood risk assessments, based on historical conditions. The climate has been, I think you could say, it's been in a state of dynamic equilibrium. But now the baseline conditions are changing in response to this persistent perturbation, which is an increase of greenhouse gas concentrations in the atmosphere. And that's shifting the climate from one state towards another one, towards a new state. And it's the pace of that shift that's really the problem. So that's one point, is that, sometimes you hear people sort of describing climate change as if we're being wheeled towards this future on a hospital cart, and it's like this unknown. It's not all that unknown. These impacts are things that we've dealt with and we know how to deal with, but we don't necessarily know how to deal with on the scale, and they may be occurring in places that haven't experienced them before. So, and then the second point is that to the extent that we're unprepared to handle these things today, we're going to be even more unprepared for them in the future. So every superstorm Sandy, every drought, every fire season in the West, every flood in Philadelphia or Miami, every one of those things is a wake-up call. And that's really, I think those are kind of two key things to take from this slide. And then, of course, the health outcomes, looking at sort of what are the outcomes that, as healthcare professional, people in the healthcare profession, these are the things that you're likely to start seeing more of. Okay, so then to the next The next slide is really just to give you a sense of scale and cost. And this is a study of just 10 individual climate-related events around the country in 2012. Now, these are not necessarily linked to climate change. I think one of the things that any climate scientist is going to tell you is that it's almost impossible to ascribe a specific event to climate change. You can't, it's really difficult to say that because the climate is naturally variable. Climate is always varied, and then weather is even more variable. But these are climate related events. And just these 10 climate related or climate sensitive events in this 1 year resulted in over 900 deaths, over 20,000 hospitalizations, almost 18,000 ER visits, and about 10 billion in health related costs, most of which is the cost of mortality. So these are, this is big, right? This is just from 10 events during 1 year. So this gives you a sense of the scale. And then, so then again, as people in healthcare, in the healthcare industry, I think there's a useful, for me anyway, one of the most useful ways to sort of look at this in terms of patients and impacts is vulnerability. So not everybody is equally sensitive to climate or equally vulnerable, right, to different impacts of climate change. And that vulnerability really depends on 3 factors. The first one that I think of is sensitivity. It's the one in the center. And that really speaks to how sensitive is an individual or a population or a community to an impact. And that could be physiological sensitivity, but it could also refer to behavioral or other factors. The classic example here is older adults, people over 65, who are physiologically more sensitive to heat than the general population. And then if we carry that same example through to the next step, which is, or the next aspect, which is exposure, to what extent is this individual or population exposed to a hazard? So again, with older adults, let's imagine there's a heat wave, but you have a group of people who are in, say, an assisted living facility who all stay indoors and they have functioning air conditioning and the electricity stays on. Nobody's actually going to be exposed. So those people, even though they're sensitive to heat, they're not going to be exposed. And so therefore, they're not actually vulnerable. And then the third component of vulnerability is adaptive capacity. And that refers to an individual or a population's ability to adapt to new conditions or to reduce their exposure, to reduce their risk of exposure. So for example, a low-income population might not be able to afford air conditioners, or even if they have air conditioners in their building, they might not run them, even if they have them, because they can't afford to pay for the electricity. So those people would have low adaptive capacity. So they would be vulnerable. And I find that this is a really useful approach to evaluating vulnerability. And in fact, when my colleagues at ICF is a, we joke that it stands for, it's a consulting firm. It actually, the original acronym, it was originally called the Inner City Fund. But now it's one of those firms that just, it's an acronym that doesn't stand for anything anymore. And Chip Goyette actually and I, he and I used to be colleagues at ICF. We started on the same day. And a lot of my colleagues there do climate change vulnerability assessments. And this is exactly how they go about doing it. They start by looking at those 3 components. And so when you look at those three factors, you start seeing that there are different types of populations and communities that tend to be more vulnerable than others. And so these are examples of some of the types of communities and populations that we need to pay attention to. So like older adults, as I mentioned, for a variety of reasons, not just susceptibility to heat. There are a whole bunch of other sensitivities that older adults have that make them more vulnerable to to the impacts of climate change. People with chronic illnesses, people with mobility challenges, right? The poor, the isolated, BIPOC populations, Black, Indigenous, people of color. Certain occupational groups. So you have, if you think of outdoor workers, right? Outdoor athletes, people who spend a lot of time outdoors and who are exposed, and women and girls. So those are some of the more generally vulnerable populations. And then finally, so the sensitivity, exposure, adaptive capacity equation isn't just useful for assessing vulnerability in human populations, but it works for everything, including buildings, infrastructure, and even healthcare facilities. So this is my last slide. Climate change also poses risks to healthcare facilities and the whole healthcare system. I think Mona has a statistic about the percentage of healthcare facilities in the US that are located in floodplains. And you'll see a couple of other examples here. I thought the one about Hurricane Maria in 2017 was interesting, where a lot of the IV bags, a large part of our supply of IV bags comes from a couple factories in Puerto Rico. And when Hurricane Maria hit Puerto Rico, those factories shut down, and there was an IV bag shortage all around the country, just from that one storm. And then there were the flooding impacts of Hurricane Sandy. There were a whole bunch of hospitals that had to shut down. Wildfires have affected healthcare centers in California. Sometimes they affect the facility itself. Sometimes they affect access to the facility. So you can have floods or wildfires that actually prevent people from getting care. And there are other aspects of this too, where, for example, the fact that a lot of people are aging in place now, as opposed to going to senior centers. So that means that you now have a dispersed population of vulnerable people. So if there's a heat wave that's coming in, or if there's a flood or something like that, and you want to reach those people, instead of just going to a limited number of buildings, you have to have a registry of everybody. You have to know where everybody is, and you have to be able to get out there and get them. So anyway, that's just my 10,000 foot overview, very brief. I can take a couple of questions if there are any, and then we can move on to Mona, who's going to provide some more concrete examples and describe some work that she's involved in on this front. So over to you, Anne, if you want to moderate the questions.
Brad, could you switch off screen sharing, please?
Yes.
So Anne, I have a general question, and I'll put it out now, and it may be more appropriate to discuss later, but using the example of hospitals running out of IV bags during Hurricane Sandy, and of course there were massive shortages of N95 masks during the onset of the coronavirus. The problem is it's really hard for a nonprofit organization like a health system to invest significant resources in stocking up to prepare for an event that may never happen, or may happen once every 100 years. And I could write the headline now if somebody wanted to go after Inova 5 years ago for being profligate with their money, saying, look, they've spent $5 million for face masks that may never be needed. You know what I'm saying? And then of course, what happens is when they're needed, they're castigated for not having foreseen it. How do you navigate that? And given that a great deal of the investment that's needed seems to fall on non-governmental entities, how do they thread that needle?
That's a really good question. And the analogy that I like to use is that trying to plan for climate change is kind of like trying to plan for a dinner party when you don't know how many people are coming or exactly when they're going to show up.
Right.
And it is similar to that. And when you do that kind of planning, right? If you do have to plan a dinner party where you don't know how many people are coming and you don't know when they're going to show up, the last thing you want to do is to have some meal where the recipe says serve immediately, right? Or you also don't want to have something that's going to spoil if it sits out. So you want something like pasta salad, right? That you can that you can add to. And you can keep it out, it stays, and you can keep adding to it if more people show up. So but it's a tricky, and that sort of speaks to like one of the approaches in long-term adaptation to climate change is something called flexible adaptation pathways, which is an approach that New York City is taking, for example, where you recognize that there's always uncertainty about the future, and we can't know the future. So let's set some plans in motion now, and then as the science develops and as we get more information, we can build in new things, but let's try to make everything as flexible as possible. So if we're putting in a dike to protect against sea level rise, let's make sure that the base of that dike is wide enough to accommodate future increases in the height of that that protection. So it's things like that. So there's always there's the risk of overreacting, and then there's the risk of underreacting. And it's like any other thing when you're planning for the future. You just have to, you have to do the best you can with the information that you have. But if you can keep things flexible and try not to lock yourself onto a path, that's probably your best bet. It's a very wishy-washy general answer, but
No, it's tough. I mean, I get that. Okay, thank you.
Anne, you're on mute, but I see we have a question from Allison.
Great. Go ahead, Allison.
Yeah, now I need to figure out how to unraise my hand, but I'll figure that out later.
Not important.
A little rusty on my Zoom. So I don't know if this is a question or just, something to contribute to the conversation. And, this was something that I was interested in looking at a previous role, and that was how is care delivery going to have to change in light of these extreme weather events? And yes, there's the supply chain impact and other impacts, but just thinking about how care delivery will be changed in the changing climate. And so one thing that has come to mind that I was looking at was a couple of years ago, I live in DC, so front page of the Washington Post, there was an article about the floods that were occurring in the Midwest. I think it was Minnesota. And farms were just being decimated, and the increase in percentage of suicides by farmers because they would just lose everything, like $300,000 in debt from farm equipment and that type of thing. And the state only had one hotline that was available for mental health or suicide prevention. And so a lot of the people that would be calling the hotline were switched over to the VA because the state just didn't have enough hotlines to accommodate the calls. So I wonder if there's a way to anticipate, yes, it's a fluid situation, but if there's a way to anticipate the impact of the workforce needs, or, like with the wildfires and respiratory issues that are increasing, how will that impact the maternal or the elderly and underserved communities, and what the workforce or the care delivery, do we need to increase the use of telehealth or other virtual care or remote patient monitoring capabilities to support the influx or the changing demographic or dynamics of the overall environment. So I don't know if that's a question or a comment, but anyway.
Yeah, I would just add to that there's actually, it's been established now a linear relationship between temperature and suicide incidents. And there's a paper by Mullins and White you can look it up. I'm sure you can find it just based on that. But they established this linear relationship. It's a very robust study. And so the information is out there. And then I think, it's a matter of getting that information into the hands of the people who need it to make decisions. And I think that's key. There's always the issue of uncertainty, but I think it's really key. Another example that I'd like to use is in New Hampshire, there was a problem where there were these floods that were washing out culverts under bridges, right? And the Public Works Department would just go in and replace those culverts with new culverts that were the same size because that's what their spec was. And then another storm would come and wash out that culvert. And nobody was telling these people that the climate's changing and we're getting bigger storms now. You need to change the specs on your culverts. And as soon as they started doing that, they started putting in bigger culverts and they weren't getting washed out. So you need to find those people, the people who are making those decisions, and get the information to them so that these kinds of things happen.
Any other questions? Well, why don't we continue now with Mona?
Okay, let me get the screen sharing going. Okay, so can everybody hear me okay?
Yes.
Okay, great. Well, I want to first thank you for inviting me to speak today. This is an area, a topic which is very, near and dear to my heart and grows in importance every day. So I really appreciate the introduction from Brad. I think, did a very nice job of summing up some of what we understand about how climate change impacts people and how the impacts can differ depending upon who people are, what capacity they have, where they live, and so forth. And so I'm going to talk some specifically about the physician's role. And as Anne mentioned, I'm a family physician. I'm also trained in public health. And I became really interested in climate change back in around 2007 when I was teaching at Thomas Jefferson University Medical Center in Philadelphia. And there was a big project across the state of Pennsylvania to try to improve the management of chronic disease. And so we had learning collaboratives all over the state, and we had a chance to meet people who worked in other practices from all over the state, and really focused in on some of the needs of people who have chronic conditions. And it was really at that point that I became very interested in what was going to happen to people who had chronic conditions as the climate warmed. So with that background, let me move into this. And as Anne mentioned, I'm at George Mason in the Center for Climate Change Communication. Our own website is docsforclimate.org. And we also have a Twitter account, which is @docsforclimate. Just by way of disclosure, I'm not making financial disclosures, but I am going to make some personal disclosures. And these are some new members, recent members of our family, who give me an added incentive every day to work on this topic. So the Medical Society Consortium on Climate and Health is a coalition that was established by 8 medical societies originally back in 2016 with the mission of informing the public and policymakers about the health harms of climate change and the benefits of climate solutions. Today, we have 32 member societies, and they represent over 60% of US physicians. In 2017, we released this report that you see here, Medical Alert: Climate Change is Harming Our Health. And in this report, which is very readable, relatable, has great pictures, we summarize the health impacts of climate change. So we released that report because most Americans, even at that time, understood that climate change was real and were concerned, but they saw it as a faraway threat, far away in time, far away in place, and far away in terms of who would be impacted. Some other people were going to be impacted not, themselves personally. And then by just last year, only a minority still thought that climate change was going to be a threat to them personally. And so the medical alert report is really intended to fill the gap in awareness. And you heard the key messages at the very beginning and shared them. And then, Brad spoke some about the specific health impacts and who is most impacted. I just want to add one focus area here that hasn't already come out, and that's pregnant women. It turns out that pregnant women are especially sensitive to heat and also to poor air quality, like the poor air that results from wildfires. And so prematurity and other poor outcomes of pregnancy do rise in situations of extreme heat and poor air quality. And there's a very significant literature on this. And in the New England Journal last year, 2 of our members actually summarized that literature, and you can find that there. And of course, that also means that people who are unable to get out of the heat or have to be outside in a heat wave, if they're pregnant, are more likely to have problems in their pregnancy and with their delivery and their newborn. So we have to address these problems or they'll only get worse. We decided to see what doctors were experiencing with regard to climate change. The question was, if we know that these health impacts are happening, are doctors seeing them? They should be seeing them. And so we partnered with 3 medical societies, the allergists, the thoracic surgeons, or the pulmonary specialists, and also African-American physicians in the National Medical Association. And we asked them what they were seeing and if it was impacting their own patients. The majority saw it as climate change is directly relevant to patient care, and 70% thought it was harming their own patients, 50% a great deal or a moderate amount, and 20% thought it was harming their own patients at least a little. These surveys were done between 2014 and 16. And we asked them what they thought should be done. They had very similar impressions of how it was harming their patients, and you can see the list of the key areas there: mental health, ticks and mosquitoes, allergies, air pollution. And they felt that physicians had a responsibility to tell the public and also their patients about all this, and that doctors should be taking a leading role on environmental sustainability in their workplaces. They wanted their societies to weigh in, and this led to the establishment of our coalition, the Medical Society Consortium. So we had to ask ourselves, are physicians really a good group to try to bring together to work on this problem? And so, why should we bring physicians together? Well, when you look at who are the most trusted professions, and you see here a chart that comes from the Gallup poll, and this is done every year, and the results have been almost identical from year to year over a number of years. Physicians are at the most trusted end. You can see over there on the left in red, the nurses are most trusted. Pharmacists and medical doctors also very trusted. And way over on the right, we have members of Congress, unfortunately, and car salespeople. And also many people get to see a physician over the course of a year, and they're used to trying to translate science to the public. So we released the report, and then we immediately started to grow. And today we have 32 medical society members representing societies that have over 600,000 members. We also have 59 affiliated public health groups. So that includes organizations like the Heart Association, Lung Association, Cancer Society, et cetera, the psychologists, the social workers. We have 16 state-based groups and also over 1,000 individual advocates who don't necessarily identify as being part of any specific organization. And we like to say that we organize, empower, mobilize, and amplify. So we organize, these are our core strategies, bringing physicians and other health professionals together. We empower, so we have webinars, newsletters, materials that they can use and learn from. We mobilize, we put out action alerts and provide opportunities to weigh in when policies are coming up for a decision. And we amplify by having good public relations. So I want to just share a couple of stories here. This is Dr. Samantha Adut, who is a pediatrician in Virginia. And her 11-year-old son, Isaac, was at band camp in 2011 when they got a call from the emergency room that he had collapsed while playing the clarinet. Well, it turned out that this was a pretty, hot year with the heat index up at high levels, and he had heat illness. So this was Dr. Adute's wake-up call, and she has become the chair of our Virginia-based chapter. This is Dr. Claude Tellez, who was now is a retired critical care doc in Louisiana. He was there when they had a 1,000-year flood event in 2016. It was a tremendous disaster, and 30,000 people were rescued by the Coast Guard. 10,000 people ended up living in shelters. You can see the big area of Louisiana that was flooded. And he gathered together with some other docs and worked with pharmacies to get medicines to people who had left them behind when they left home. This is John Meredith, who is an emergency medicine doc in North Carolina. And he was on duty there when there was a terrible wildfire in a bog in 2008. And they had a tremendous increase in people presenting to emergency rooms with all kinds of respiratory complaints and cardiac complaints. He and several of his colleagues did a study that which they looked at the counties that got the plume and counties that didn't get the plume. And they found out that counties that did get the plume had a 50% increase in all kinds of respiratory conditions compared to those counties that didn't get the plume. And they also saw this increase in cardiac events. And finally, this is the story of Nitin Damle, who's an internist in Rhode Island. And he has a practice that includes a number of partners. Each of them used to see 2 to 3 cases a month, 10 years ago. And now they see 40 to 50 over the course of tick season. And it's not just Lyme disease, it's all kinds of other tick-borne illnesses. So the doctors wanted their societies to speak out. They felt they had a responsibility to let the public know. They wanted continuing medical education for themselves and medical students. And they felt that doctors should be involved in environmental sustainability in their workplaces. So I'm going to skip over this, but this is some of the advice that doctors can give their patients when, in light of all these various exposures that people are now facing. There's some very specific areas of advice that they can give on allergies, on what to do in case of wildfire, especially if you've got a respiratory condition, how to keep yourself safe from mosquitoes and ticks, and how to handle mental health issues, and especially for people who have pre-existing diagnoses. Most of the medicines that people take for mental health problems are actually heat sensitive. And so this is something that doctors and pharmacists should be sharing. Several years after we formed, we put out something called a policy action agenda, which is our kind of list of things that need to be done to prevent health impacts and to also make ourselves resilient. And we started by letting people know that climate change is really a health emergency. And that policy action agenda now has endorsement by 188 organizations of medicine, nursing, and public health, schools of medicine, nursing, and public health, and hospitals and health systems. And only one of those 188 is a group that represents 500 hospitals. We are currently trying to take all of this to the Department of Health and Human Services and to get HHS to increase the expertise in each of the various agencies and offices within HHS, because that expertise does not exist today. So this policy action agenda that I mentioned, as I said, declares climate change a public health emergency. It's a 10-point agenda, and 6 of those 10 points actually provide direct benefits to health in addition to addressing climate change. And some of them that will be familiar or maybe not be familiar are the extent to which focusing on energy generation and energy efficiency can impact health and also address climate change, how we do agriculture and use land, it turns out can have an impact on health and also can address climate change and transportation. And we know about 25% of greenhouse gases come from transportation sources. And, that comes up currently because Congress is considering a transportation and infrastructure bill with the reauthorization. That's a must do for this year. It was supposed to be done last year, didn't get done, needs to get done this year. And transportation is a major source of pollution in addition to greenhouse gases. So there is one of the 10 points that's on the need to help communities with the transitions that need to be made to address climate change, either to make them more resilient or to help them overcome the economic challenges, which, we realize are considerable. Coal communities are a great example of that. Coal has been declining over a number of years and needs to further decline to be able to address air pollution, because coal burning, it turns out, produces, some of the worst air pollution and also some of the most carbon dioxide. So anyway, communities that produce, some of these resources like coal need help. And so do communities that are endangered by virtue of where they're located, where they face floods or storms or fires. And then two of the provisions specifically address health professionals and the environmental footprint of the health system. And so the health system itself accounts for almost 10% of greenhouse gas output today. It's an energy intensive enterprise. And those hospitals that are part of a group called Healthcare Without Harm are trying to decrease their energy use, decrease energy waste, improve their food systems. And you'll hear more about that from Chip Goyette, who speaks after me. But we believe health professionals, have a direct interest in all this and should be involved and are interested in being involved. And we're working to bring them forward and also are, united with the Healthcare Without Harm organization in feeling that we have to improve the environmental footprint of the health system itself. And then one of the 10 also addresses research and investments in research and HHS and so on. And so that's a big area of focus. So this is just a picture of some of our doctors. This group is out in California. And we like to say that climate solutions are health solutions because clean renewable energy emits no greenhouse gas and doesn't pollute the air. Active transportation, where people walk or bike or take public transit, and zero carbon transportation is better for health. And of course, electric cars and so forth don't pollute the air either. And so this is better for health. Diets with more vegetables and less meat mean less methane gas into the atmosphere. They're closer to Mediterranean healthy diets. And better farming methods could enrich the soil if they used the best methods and less fertilizer, which runs into waterways and ends up creating dead zones where fish and no animal life is able to survive. And cities with more trees and greenery absorb more carbon dioxide and protect people from the heat because they transpire, meaning they put moisture into the air, which evaporates and cools the air right around the greenery. It's not just the shade, it's also the transpiration. So I have some more slides here which go into more detail about our kind of core strategies. But in the interest of sticking to my time allotment, I'm going to stop there and hopefully we can either go to questions or move on to hearing from Chip.
Thanks, Mona. Because I have a question, but I will defer first to the audience if they have any questions. Nobody's speaking up.
Okay,
Mona,
I'm still showing some slides there. I'll stop sharing now. Sorry. Okay.
No, okay. Whenever you're ready.
Okie doke.
My question has to do with credibility in Congress. I think you showed a bar chart early on about how nurses, pharmacists, and physicians,
doctors, yeah,
have the most credibility. And I was looking and I couldn't tell where perhaps our political folks were on that spectrum. But when I get a little bit passionate about some things and often yell at the TV set. So when our former president started talking about how windmills, and these new wind farms were causing cancer, I was always screaming at the set. It's like, where is the American Medical Association? Where are the physician organizations saying this is nonsense? And of course, they were silent. And I was really upset about that. And I was just wondering, is your organization now creating a willingness on physicians and their organizations that represent them to speak out publicly?
Well, I'm very glad that you asked that question because we are trying to be heard on a lot of topics, and of course, we're somewhat dependent upon whether the media calls us to comment. So we have a public relations effort going, and we've got an excellent public relations team, and the amount of material out in the media has increased dramatically that focuses in on health as a problem. But when it comes to some nonsense like that, about windmills and cancer, we have not necessarily put out statements about it because it just seemed so absurd, but you raise an interesting question. Maybe we should put out a statement.
And I'll ask the question for Mona. First of all, thanks very much for the talk. My question is about evidence. Is as VP of clinical research for a telemedicine company, I'm very focused on evidence for interventions that we're working with. And of course, you said that a lot of folks have trouble seeing, okay, this problem affects me. I'm wondering about forward-moving efforts, and maybe Allison could chime in on this, of things like maybe a registry of potential patients that could have environmental impact. So it could be, let's say, pregnant women in California versus pregnant women, let's say, in Florida. So two coastal places. But California has been having a lot of wildfires. And so maybe over a 2-year period, you track and you have a registry of pregnant women. And on average, every couple of years, you're going to get some places, whether it's Oregon or Washington or California, with these massive forest fires, which really, I was down in LA last summer, and those fires all the way up in San Francisco, you felt it in LA. So things like you're talking about women's susceptibility who are pregnant to heat, and I would think also air pollution. I'm wondering about thoughts to really trying to create an evidence base so that will, let's say, create more momentum in Congress, alleviate some of the doubts of the doubters, that kind of thing.
Yeah, that's a good question. Normally, the people that we would rely on to do that kind of work are in public health departments. And we have not really recovered from the cuts in the public health that occurred after the 2008 downturn and the loss of tax revenue. And the decline in government support that occurred at that time. Public health departments around the country, where I think we've lost 40% of the person power that was in public health departments, and that has not recovered. And so some of what is currently happening in Congress is to try to, to build back local and state level public health departments so that they could think about things like creating registries or, having more systematic way of reaching those who are vulnerable. And I think many states are trying. Of course, the CDC has had their BRACE program, an excellent program, which is Building Resilience Against Climate Change Effects. And so they've supported 16 states and several cities and a couple of tribal governments to evaluate what kinds of dangers their populations face, to try to measure those, and then to put programs in place to protect those people. And that generally is considered to be under the heading of adaptation as opposed to mitigation. So, that's in health language, maybe protection as opposed to prevention. Prevention would be about preventing further decline of the atmosphere, and protection is about protecting people. But in any case, there are, I think in the budget debate going on now, a question about providing funding to the CDC so that they can support more states to do that kind of work. We're really behind in doing that at a governmental level. And that, you know, we need that attention. We need people to know that. And I think, you know, folks like yourselves who are so involved in health policy are in a key position to be able to share that we really are behind in building up the structures and the expertise that's needed to protect people against climate change. Because, you know, if anything, if you needed anything more dramatic than 126-degree temperature, you know, yeah, you know, or 117 in Phoenix. I think it was 126 in Death Valley, but 116 in Phoenix. You know, I don't know what that is. I mean, I guess Superstorm Sandy, you know, all of these extreme events really show just how much we need to increase our, you know, our focus on protecting people. And that includes protecting the health system. Brad mentioned before that, you know, I shared that 400 hospitals are in flood zones. So I don't think right now CMS has any requirement that hospitals show that they're resilient against flooding. You know, that could be a really easy thing for CMS to do, to put those kinds of requirements in place to make sure that at least our health system was, you know, was resilient. Of course, we have problems with rural hospitals, you know, there's been, anyway, you guys know, I think a lot about the health system. We have a lot of issues, but protecting people is really important.
Well, now that you mentioned retention, resilient hospitals, that's a great introduction to Chip. So Chip, why don't you go ahead?
Great. Thank you, Anne. And thank you again, everyone, for sharing your Friday afternoon with all of us. This is, you know, great conversation. So what I'm going to do today basically is kind of take you through the end here and kind of give you an example of one, you know, what one health system is doing, right, to kind of connect this message of sustainability and health, public health or climate health. So to begin with, though, there's just this wonderful video that we like to show that basically kind of encapsulates this whole thing. So I'll push it over to Dr. Nick to show this video real quick.
Like most doctors, I began my career by swearing my allegiance to the Hippocratic Oath. As a pediatrician, I was so proud to be part of the tradition of the ancient doctors who swore, in the same spirit as we do today, to treat the sick and protect them from injustice, and above all, to first do no harm. Since the times of Hippocrates, medicine has evolved in unimaginable ways. Inside our clinics, we've become brilliant at treating our patients' symptoms. But outside our walls, some of these illnesses are growing to epidemic proportions. Of course, we ask ourselves, what is making people sick in the first place? And why do they keep coming back? In our journey to diagnose and treat the body, we've been to the moon and back many times over, masters and explorers of the very small. But 20 years ago, some of us saw that to understand the problem, we had to take a wider view. From that vantage point, we saw thermometers, each containing enough mercury to poison an entire lake, piled up in our trash. From an even wider lens, we saw medical waste incinerators on our own properties throwing toxic fumes skyward. Dioxins and mercury from waste incineration fell to earth, entering the water we drink and the fish and animals we eat, poisoning our bodies and the developing brains of our children. Our own fingerprints were all over the scene. We were contributing to making our own patients sick, all in direct violation of the oath we had sworn to do no harm. So we formed a coalition of doctors, nurses, and advocates to push back, and pushed healthcare to stand with our oath and clean up our own house. Today, only a handful of incinerators exist in the US, and mercury thermometers are going the way of the horse and buggy all around the world. But while you listen to me, the climate is changing, and the people we serve face perhaps the biggest harm of all. Now we need healthcare to be a leader within this widest scope. Look at healthcare's global footprint. We consume huge amounts of energy on every continent, contributing to climate change and air pollution that kills 7 million people a year. In the US alone, healthcare is responsible for 8% of greenhouse gas emissions. But here's our leverage. We are 18% of the US economy and 10% of the entire global economy. The changes we make really can move entire industries away from harm and set new norms that will positively impact our patients' health. Imagine, for instance, if healthcare fought antibiotic resistance by purchasing only antibiotic-free meat, or how innovative solutions to eliminating waste, like biodigestion, could help power hospitals and reduce air pollution around the world. Healthcare could help make renewable energy viable. By choosing to turn away from fossil fuel, we would reduce the carbon emissions that harm our patients and our planet. We stand at a turning point in the course of medical history, and we can move to a tipping point. It's within our power and our mission. Dr. Martin Luther King said the moral arc of the universe bends toward justice. Join us as healthcare bends toward a more just and sustainable future, rooted in our original oath, do no harm.
Okay. So that's a video that I think was produced now almost 5 years ago. And, you know, it's something actually we showed to our new team members at their new kind of employee orientation, right? So you step into Inova basically, and that's one of the videos that's all shown to all of our newest members, so they can kind of get that flavor in terms of why sustainability, right? Why do we do the thing we do? There's that, obviously there's that connection to health. And so I'm going to start sharing my slides here. And again, I will make sure I put the link to that video in the chat a little bit later, because I know, you know, it's pretty powerful to watch that video when you're in person, right? Especially when you're with an audience and so forth. And so, and it's on YouTube, so it's welcome for anyone to, you know, to show it if they'd like. So Inova, and I'll only spend real quickly, you know, I think everyone knows who Inova is, or if you don't, I mean, we're a large nonprofit health system in Northern Virginia. You know, we do everything. It's kind of soup to nuts kind of health system. You know, we operate 5 very large, you know, acute care hospitals. They encompass about 2,000 beds, and our team members, our employees, I mean, it just keeps growing. We're up to well over 18,000 team members across all of Northern Virginia and even beyond, frankly. We serve 2 million patients a year. And so what this is meant to do is just kind of show how big our impact really is, right, on the region. You know, when we're growing, of course, right, we're not only kind of expanding our footprint through different practices that we're either merging with or buying and so forth, but we're developing right now 2 brand new hospitals, one in Springfield, one in Alexandria, along with another brand new healthplex, all that are expected to be open by 2030. There'll be another 1 million square feet kind of coming online with Inova. And so again, our footprint, it's just huge. All right, everyone can see these slides, right? Thumbs up, okay. Why they're not moving. Let me see, try it again. Okay, all right, so this is now, you know, where I think sustainability can come in, right? You know, we obviously have a huge or pretty large environmental footprint impact, and so sustainability can then become that vehicle or mechanism to kind of reduce those impacts and contribute to a better health environment, right? So it all starts with our mission, right, which you can see here again is embedded in health and establishing an environment that's safer and healthier for everyone, frankly. And we use these principles to kind of apply to all of our programs and initiatives that we put in place, right? And it's frankly, you know, all about the first one here, which is do no harm, right? You can't have healthy people on a sick planet. So we really try to take that to heart in all the programs or projects and initiatives that we put forth and we execute. All right, so, but to do that, right, we obviously need our teams and our different functional areas and even leadership to kind of be on board with us. And so, you know, sometimes we might not fully lead with health or climate health. We frankly sometimes have to lead with the issues that are most important to the folks we're talking to, right? Because I think we all understand that, you know, there in healthcare, there could be a different crisis every day, something they're dealing with. Obviously, over the last year, we've been in the response to a pandemic that none of us have seen in our lifetimes and so forth. And so, we're the ones here bringing sustainability, and sometimes it might not seem to fully resonate, right? It's like, why are you bringing kind of this to me when I'm focused over here? I'm saving lives, right? And so what we really try to do is we really try to mesh our programming and connect our programming with the different priorities in the organization. So under Inova's mission, vision, and values, the big focus is really, patients are obviously tantamount, they are the priority, but so are our people as well, right? And so you can see on the left-hand side, basically these are initiatives or messaging that we use, in dealing with folks like human resources, dealing with the heads of departments or units and so forth. And again, even dealing with our leadership, right? I mean, HR is tasked with bringing in people, right? So we don't have the people, we can't meet our mission, and we got to then keep those people, right? Because we don't want to be then retraining a brand new workforce all the time, because then that becomes costly and expensive. On the patient side, we've been able to kind of show those connections or nexus between things like clinical outcomes, reductions in risk, and even cost decreases that may be more important to, say, our facility side, or purchasing and procurement that really has to focus on the dollar, right? And see how can we still meet our mission but by also saving some money where we can. And, I just wanted to kind of allude back to a few questions that were posed earlier. When you're talking about, I think the question was related to what's going to happen if 5 years ago, Inova purchased all these masks or these other things, personal protective equipment, that we spent all the money and it all went bad, right? And so we had to throw it all out afterwards, right? And so what we've always said initially is, well, the first focus is reuse, right? Is there a reuse opportunity available? And it was fascinating to see with the masks, the N95 masks as an example, and it wasn't just Inova that did this, but other health systems were able to use their sterile processing to actually sterilize the masks after our team members use them and kind of extend the life, right? So we never ran into the issue at Inova of running out of masks for our team members. Same thing for gowns, for isolation gowns and so forth. That's a disposable product typically that during the pandemic probably went up 10 times in cost, if not more than that, right? So you're talking about a gown that basically cost nothing initially, and now you've got this big cost in front of us. So we went with a pilot to go with reusable gowns that we could then launch our laundry facility, and now it looks like it's going to be an initiative that is going to continue beyond COVID, right? And so again, it's always interesting because, these are things that we've always been talking about, but they've now come to the forefront. And I think there's a huge opportunity now with sustainability, talking to the different departments and how we truly can be that mission-centric kind of entity that really will do more, frankly, than help Inova meet their, overall mission of providing world-class healthcare. And so that's been really powerful, I think, in this entire pandemic. And so kind of moving from there, it's not obviously just about the messaging, clearly that we have to put in place with the leaders, but it then also becomes the programs, right? And I've got these next two slides to just show quickly some of the recent initiatives that we've done. Straws and styrofoam have been interesting, right? We've always had, again, a desire and sustainability to get rid of single-use items, single-use plastics, particularly in our food services. The straw initiative was fascinating because that really came from our CEO. Our CEO began with us, I believe, in 2018, in the spring of 2018, and he felt that we need to get rid of straws, right? From more of a public health standpoint. And granted, even though it was on our radar from a sustainability standpoint, it probably didn't rise to the top because it's a very small percentage of our waste stream, as an example, right? But one of the things that we learned now is that, our CEO was definitely more probably sustainability conscious than we had originally thought. And he frankly also wanted to be in front on that issue. So there's this, I think this motivation of being a leader as well, right, in the community. And so we now kind of have that to understand that our CEO is definitely really interested in that. And so then in a year later, again, we have been trying to eliminate styrofoam ever since I began at Inova, which is now more than 5 years ago. And we know we had, interest, again, with leadership. We then partnered with some doctors at Inova that also had a big interest in it. And then lo and behold, it was an initiative that started at one facility. And frankly, everyone said, well, we can't just do it here. We have to do it everywhere. And it just snowballed into all of our cafeterias eliminating styrofoam for a more, I guess I'd call it environmentally friendly paper alternative that we have in place now that is also biodegradable. So we can also move maybe next year to more composting, and we've got potentially items that we can divert in the waste stream moving into the future as well. And I bring those two up specifically because they also kind of go counter to what we might think about as a driver for leadership, because both of those initiatives cost money to implement than the existing case, right? It's typically why hospitals have so much difficulty with styrofoam, is because it's just so cheap, right? It is, but when we termed it kind of in this public context, right, of saying, well, it's really not good to put hot food on styrofoam because then it can leach into your food and you're eating that, and it's just not healthy. And so again, we were able to make that happen, which was fantastic. And then some of these other initiatives as well, in addition to those two, they really resonate with team members, right? Team members see the awards that we're receiving, or they see these programs on the ground, and they become really, really proud to work at Inova and be part of everything that's going on at Inova, which again, I think personally then leads to better patient care, right? It's that happy, healthy employee becomes a more productive, right? And really does just fantastic on the patient care side. All right, these are some more, and I know I'm probably getting close to time, and so I've got a few other examples I want to get to. Transportation-related events, again, these have a big impact or big benefit with team members. Again, I think food was brought up also in a question, so in our food offerings with our food service provider, we have a number of metrics in place around sustainable and organic to make sure that we are offering the healthiest food available. And we also have a CSA, a community supported agriculture in place, to support local farmers, right, to make sure we are basically a part of that initiative, to make sure, our local farmers are whole. And we also have, frankly, a local requirement with our food service provider as well to buy, say, X%. I think right now it's at 10 or 15%, but we're looking at bumping that up as well to make sure, again, we're supporting local, right? And then, again, on the employee or team member side, I mentioned earlier, a big focus that we look at is, how do we not only help kind of the public health and environmental side of things, but also certain departments that really are doing things. How can we highlight those departments that are doing things because they help them achieve their mission of whatever it is they're doing, right? And so we be kind of the director of language and disability services. Most of their work, or a lot of the work they can do it remotely. So they really push telework. And frankly, I believe they've even got a few team members that don't even reside in Northern Virginia, right? Because you're talking about translation services, all sorts of services to our patients. But they realize that it's a strategy that can actually help them keep their top performing employees, right? And so, we look at this as a way to, again, in healthcare, we might not think about, well, people teleworking, right? Because we're seeing patients and so forth. But again, it is something that I think not only helps meet with, helps this type of organization or department in our hospitals meet their mission, but, with COVID in response to the pandemic, it was a huge strategy put in place for all of our administrative team members, right, to keep them home and to keep them safe. And again, and we foresee that continuing well beyond COVID, where I believe, it looks like telework is definitely here to stay in Inova. And then, of course, the environmental benefits are significant. So these are just some more, initiatives that we have in place related to our commuting programs. And again, more focused on the team members and employees. I really wanted to mention this commuter challenge quickly because this is something that we do every year at all of our hospitals. And the results are fascinating, right? Because it really brings out certain team members that you might not expect. And so the one we did a few years ago, our food services team members were the ones that actually implemented it the most. And it wasn't just for kind of the smart trip or the financial benefit they were going to get. It also really turned into kind of this team building and just fun exercise for them. They wanted to win, frankly. And so they got pretty much, there were certain hospitals, their entire food services team were just focused on taking alternative transportation to work, which was, again, fantastic. Because I think some of them didn't even realize that, well, it's not as difficult as I thought it might be. It's fun. And again, there might be some cost savings with it. And I will say, we also connected it back to the environment and back to health. And they felt like they were doing their part, right, to kind of reduce pollution, which again is obviously key in all this. So the last thing I want to look at is, some of the patient things we are doing. These are a series of booklets that we developed again a few years ago. We're putting them out through some of our different, I would say, doctors' offices. Some of our clinicians have these to, again, educate kind of the vulnerable populations that are out there to climate change. And then the last thing I want to mention, and this is, full disclosure here, this is not an initiative at Inova, but this is something, this to me is kind of the pinnacle of why or how sustainability in these strategies can just impact a variety of different things. So this is an example from a psychiatric elderly facility in California. And what it is, kind of in a nutshell, it's just a new lighting project to install tunable, dimmable lighting, right, in this wing of this facility. And the intent of this was to obviously have energy savings and some cost savings and so forth, but did it really affect outcomes, right, of our patients and our team members and so forth? And so they installed this lighting, and what it's meant to do, it's meant to mimic our circadian rhythms, right? And so in the morning, lights a little brighter with LED lights, right? Waking everybody up, so to speak. And then as you get through the day, the lights are tuned down and dimmed down, basically. And then even at night, as an example, instead of having bright lights, say when a patient wakes up and has to use the restroom, you've got this amber glow, right? So it's not fully waking that person up, but it is certainly eliminating fall risks. So the results of all of this are just fascinating, right? Because they did a full study on before and after of what the impact could be of kind of this technology. And as you can see here, there's a significant reduction in, certain behaviors and things with patients, right? Sleeping in their beds, reducing sleep medications, all these things, and even seeing residents kind of hanging out in certain areas that had the lighting, right? Just because, again, the way it was, the way it made them feel and so forth, which again, I think is kind of, again, where where we're hopefully a number of us are going with this, to not only use, whether it's the food or other things, but lighting as a true strategy to impact health and so forth. And then, oh, by the way, you had 70% energy savings, right, related to this project. So again, quite beneficial. And so we certainly couldn't do this alone. We worked with a host of other healthcare partners and systems. This is the Healthcare Climate Council that I think was mentioned earlier. We're one of about 20 or so kind of working on this nexus between, climate, public health, and sustainability and so forth. We get together regularly. We share ideas, what works, what doesn't work. And, I'm really glad we had the chance to kind of present to you all today, because we not only need these partners, but we obviously love to work with you all as partners, and anyone as partners, right? Whatever your interaction is with the health system or hospitals and so forth, to kind of continue to spread this message and work on, whatever that initiative is, to kind of, again, use sustainability and kind of these other programs as a means to basically enhance health. And so I know we're almost out of time, so I am going to stop there. And thank you again, and obviously take any questions.
You're on mute, Anne.
I did it again. I was going to say, I was going to ask anybody for questions, and I have one if nobody else does. So I'll go ahead. Chip, I was born and raised in New York City, still kind of my home when I talk about it. But when I go back, because I don't go back as often and everybody there is gone for me, I get very, after 3 or 4 days, I get tired of the noise. Last night, I was reading an article in The Scientist with regards to the effects of noise on the central nervous system. And I was wondering if you're conscious of noise factors in a hospital, or, is that even come into your consideration?
No, that's a great question. We do, it's interesting. I believe that, I'm trying to remember some of the different certifications out there, whether it's LEED or a WELL standard. So when we build a new building, or we do fit outs of buildings and so forth, we try to follow the LEED certifications. A number of our buildings and facilities are LEED certified, some silver, and others that. If we can go beyond that as well. And what we do try to do internally is then also incorporate some of these WELL standards, which not only incorporates kind of the environmental side, but also, just like you had mentioned, some of these, I guess, other more health-related benefits. And so I'm just trying to think through and remembering our checklists and other things to see if we have those in there. I can't remember exactly if we have it on the top of our head, but we would certainly do things like noise related to the outdoors and so forth, right? We're not in the most rural location. We're still suburbia, so to speak, where most of our locations are located, but we do have some hospitals that are close to roads and so forth, and certainly have noise. And I know for sure that aspect is considered, but internally it can be tough sometimes with, especially if you're in a emergency department, for instance, or an ICU department, you do have machines beeping and so forth. That can be challenging for sure. But I do know, again, on the built side, the built environment, which is where I'm more involved, there's certainly, looking at that and incorporating it, I know for sure, from the outdoor and the external side of things.
Thank you.
Well, Anne, I'll chime in a question. It's both for Chip and for Mona. One of the things we do at Health Tech is we try and encourage, new companies and help them make connections where we can. So let's say there's a company, I don't know, maybe it's this one, doing lighting, or maybe it's a company that's trying to foster more wellness environments and better, sustainable food connectivity to the community. And they want to interface with this council of health systems, Chip, that you projected up there. How do companies, get into that ecosystem and participate with you to try and really make these new businesses of the future. And interestingly, just the other week or just the other month at Health Tech, we had folks present from George Mason's new entrepreneurial centers that are all cropping up partially around Amazon's new headquarters in Virginia. So how do we make it easier for those new companies to connect the dots to this new sustainability effort, which looks like that was a nice national set of health systems.
Right. Oh,
That could either be Chip or Mona.
Yeah, I don't know if you want. I could start just real quickly. I mean, the Healthcare Climate Council is administered through Healthcare Without Harm and Practice Green Health, and they're certainly an organization that brings ideas and initiative to the council members all the time. They can reach out to them directly. Again, it's the Practice Green Health or Healthcare Without Harm. And so that would be one thing to consider. And then frankly, I mean, I'm always open to talking to individuals and see if there's, a good connection, if there may be something that we haven't thought, like right now, for instance, we've got a new food vendor that's come into a few of our hospitals, and they're going to be selling local organic items through a vending machine, which is kind of interesting, right? To kind of serve the overnight market, right, at some of our hospitals. And then everything that comes out of it, if it doesn't get sold, and again, it's still, good, basically hasn't expired, it will then go to either, some food pantries or kitchens and so forth. And then the remainder goes to, say, a food composting facility. So,
great. Any last questions? Well, then I'd like to thank our speakers. You're really an awesome bunch. Who knew that we could get such people on target for this type of topic that we've never done before. So I thank each of you, Mona, Brad, and Chip, for participating. And Jim Oakes, do you want to say anything about close out the session?
I want to make one brief comment, and that's that I particularly appreciated Chip's comments about some actions being economically positive and not cost. It's always fascinating to me to find ways. I mean, I think people are endlessly focused on their own self-interest, and I think anytime you can find a way to help people do the right thing and make money at it or get a positive economic return, you're ahead of the game. So that was very encouraging to me. Having said that, I really enjoyed Mona's presentation and Brad's as well. Excellent set of presentations, and I look forward to learning more about this. So thank you.
Most of all, I'm heartened that there are people out there with the experience who are trying to make a change, because I worry about this topic a lot. Thank you all.